So welcome back to part 2 of the acute stroke management lectures. As promised, in this lecture we're going to discuss interventions for ischemic stroke, including TPA and thrombectomy. We'll also go over immediate post-stroke management that you should be aware of. So let's jump into it. So the first and probably the most famous management of acute stroke that we'll discuss is the use of tissue plasminogen activator, or TPA. As you probably know, TPA is a clot-busting medicine that works to open up the vessels of an ischemic portion of the brain. TPA is shown to be very effective in doing so up to 4.5 hours, and in fact we often use it up to 6 hours, or if we have a favorable wake-up MRI like we talked about. That said, TPA of course comes with the risk of severe bleeding, and so we have really strict inclusion and exclusion criteria. To be considered a candidate for TPA, you have to be within the appropriate time window, and you have to have a significant and persistent neurologic deficit. Typically that's defined by an NIH greater than or equal to 5. But there are certain deficits such as aphasia, visual loss, hand weakness, like we talked about, that you may not score as high but still considered severe. More importantly, though, you have to be really aware of the exclusion criteria for TPA. By far the most important one that you must absolutely rule out is any evidence of hemorrhage on head CT. And this is why a non-con head CT is obtained in every stroke. Another contraindication that you should always be aware of is hypertension. A systolic blood pressure greater than 185 or a diastolic greater than 110 are contraindications to TPA. This doesn't mean that they're completely unable to receive the medicine. It just means that you have to lower their blood pressure first with medications like IV labetalol or Hydral. And then, as I've hopefully beaten to 100 times, hypo and hyperglycemia are both contraindications, as are thrombocytopenia, warfarin use with elevated INR greater than 1.7, and the recent use of DOACs. Additional contraindications based on history include recent head trauma, recent large stroke, history of brain bleed, GI bleed, and then sometimes surgery or pregnancy. So when given TPA, there's a few complications you should be aware of. Of course, the most common and most severe is bleeding. TPA is meant to thin your blood, so obviously that's a risk. And this is why we monitor patients who receive TPA very closely with frequent neuro checks, and we really have a low threshold to send them down for a repeat CT scan. Another interesting side effect of TPA is bradykinin-related angioedema, which we actually see in up to 8% of patients. So TPA affects a similar pathway to that ACE inhibitors affect, and so it causes angioedema in a similar fashion. And people who are actually taking ACE inhibitors already are at even higher risk of developing this. Luckily, the phenomenon, though, is it's fairly mild and usually transient, but I have seen patients who ended up being intubated for it. As always with angioedema, you treat these patients with epinephrine, steroids, and histamine blockers if it becomes severe enough. Interestingly enough, TPA-related angioedema is often unilateral and is typically contralateral to the side of the stroke. I honestly don't know the pathophys behind this, but it's pretty neat. Okay, the other key intervention in acute stroke I want to talk about is the use of thrombectomy to retrieve clots. This is sometimes referred to as EVT, which stands for endovascular therapy. But we usually call it thrombectomy. Acute stroke care was revolutionized in recent years by two groundbreaking trials, DAWN and DIFFUSE 3. Both of these trials demonstrated that thrombectomy was not only effective, but actually superior even to TPA in ischemic stroke caused by anterior large vessel occlusions. I'm not going to go into the details of these trials, but they're really important in our field, so I hyperlink them in case you want to read them. In order to become a candidate for thrombectomy, your last known normal has to be within 24 hours, and you have to have a significantly debilitating stroke, typically an NIH greater than 10. And in addition to this, you must have occlusion of one of the proximal large vessels of the brain. So this is either the carotid arteries or the proximal MCAs. Studies didn't evaluate the efficacy of going after posterior circulation strokes, such as basilar strokes, but will often also do this because they can otherwise be fatal. And finally, if they meet all the above criteria, we have them undergo a CT perfusion scan, like we already discussed, to make sure they have enough reversible damage to make the procedure worthwhile. In order to assess how effective a thrombectomy was, we used the grading score TICI, which you'll hear a lot on our service. TICI is a score that measures how well the vessel was opened, with 0 being none and 3 being complete reperfusion. In a TICI score of 1, we achieve minimal perfusion, and in a TICI score of 2, we break it down into A or B depending on how well we partially fill the vessel. Remember, TICI score has nothing to do with functional outcome in a patient, it only is how well we open the vessel. That said, it makes sense that patients with a TICI 3 reperfusion typically do better than those with a TICI 1. Honestly, when performed in time, thrombectomy can be miraculous. I've seen patients go from completely hemiplegic and aphasic to totally normal in a couple of minutes. And even Willow here thinks that's worth celebrating. It's one of the coolest things we do in medicine. Okay, in the final part of this lecture, we're going to talk about how to manage these patients in the immediate post-stroke phase. So this differs slightly based upon if they received intervention or not. So first we'll talk about patients who did not receive TPA or thrombectomy. First things first, we always admit these patients with telemetry monitoring in order to evaluate for AFib, as it's a possible cause of stroke. Another important thing to remember is that patients who just had a stroke should always be NPO, as dysphagia is a frequent sequela of stroke. Often these people have no issues with swallowing, and so the nurse can just do a bedside swallow test to clear them. But we often will have these patients formally evaluated by speech therapists before advancing diets. In addition to this, during the early part of stroke hospitalization, it's vital that patients have frequent neuro checks. This can either be done every 4 hours on the floor, every 2 hours in step down, or every 1 hour in the ICU, depending on the severity of the stroke. And the reason we pay so much attention to the neuro exam in stroke is because we really want to stop the potentially fatal sequela of swelling with eventual herniation. Luckily, we do have a few measures to combat this if it really becomes severe, and one of these is the use of hypertonic fluids, and typically sodium. So low levels of serum osms can cause fluids to enter neurons and lead to cerebral edema and eventual herniation, and so it's actually not uncommon for us in the neuro ICU to target iatrogenic hypernatremia, levels as high as in the 150s. For this reason, it's really important to never ever give a patient hypotonic fluids such as lactated ringers, as you can acutely worsen cerebral edema. In the most severe cases, however, we can't keep up with the swelling in the brain, and so really our only option to relieve pressure from the brainstem is to have our neurosurgery friends perform a craniectomy, where they actually remove a large portion of the skull. As you can see here in the brain, this allows the brain to swell externally out of the skull without compressing portions of the brainstem. Usually this procedure is reserved for patients with very large MCA or ICA strokes, or patients who have posterior fossa strokes, as swelling of the cerebellum can easily compress the brainstem. One of the other important things that we do to reduce swelling is aggressively control temperature and fever. Fever can actually cause the brain to become hyperactive and may lead to swelling, and it's kind of a similar concept to why we use hypothermia in post-arrest patients, though that's a separate discussion altogether. Another incredibly important part of post-stroke care is understanding blood pressure parameters depending on what type of stroke the patient had and what treatment they've received. In a patient who has an ischemic stroke, the body knows that not enough blood is getting to the brain, and so will attempt to auto-regulate and push the blood pressure very high. As long as this does not reach a level so high that it could cause hemorrhage or dissection, it's actually quite beneficial for our patients, and so we allow for what we call permissive hypertension, as high as a systolic blood pressure of 220 or a MAP of 140. In fact, we sometimes have patients who benefit so well from these high blood pressures, we call it a pressure-dependent exam, and we will actually use pressure therapy in the ICU to help them reach higher levels. I really want to re-emphasize this. Permissive hypertension is a very important concept that's often misunderstood. It's uncomfortable to see a patient's blood pressure sitting in the 190s, and nurses are probably going to call you asking for blood pressure lowering agents. You really should resist the temptation to treat this, because unless you're treating numbers in the 200s or pushing 220, you're going to end up just doing more harm than good with your blood pressure management. Okay, so now once you understand how to manage a patient post-stroke without TPA, you can easily translate this to a patient who received TPA, as it's pretty much the same with a few key changes. The most important of these changes is, again, in our blood pressure goals. So remember, in ischemic stroke, we allow for auto-regulation as high as 220. In these patients, they still benefit from perfusion of the brain, but the administration of TPA causes them to be at a much higher risk for hemorrhagic conversion. And so for this reason, we're a little more aggressive with blood pressure management, targeting systolic blood pressures less than 180. Another important difference in patients who have received TPA is that they need even closer monitoring from nurses. Neurocheck should be performed every 15 minutes for 6 hours, and then every hour for the first day. And furthermore, you should always perform what we call a stability scan 24 hours later to make sure that the TPA didn't cause any iatrogenic hemorrhage. Of course, if you see even a whiff of a changing neuro exam, you really need to send these patients down for an emergency CT to rule out a bleed. And speaking of bleeds, hemorrhagic strokes are managed differently than ischemic strokes. Again, the most important thing to understand here is blood pressure control. By aggressively lowering blood pressure, we reduce the risk of hemorrhage spreading within the brain, which is the main cause of morbidity and mortality. Our goal here is a systolic blood pressure of 140. I attached a couple of stroke articles that are really famous called Interact 2 and Attach 2, which demonstrated that morbidity increases significantly at 160, but adverse events such as AKI or watershed occur at 120. So that's why our sweet spot lies around 140. This is really a delicate process, and so this is pretty much always performed with an arterial line in the ICU. And one other important thing to always remember with hemorrhagic strokes is that anticoagulation and antiplatelet therapy must be reversed immediately using therapies like PCC or FFP. And then in these patients, we also wait significantly longer to restart anticoagulation than the typical ischemic stroke patient. And that's it. That's just a taste of the acute care of stroke, from how to run a code stroke to what intervention to use in these cases to how to manage these patients immediately afterwards. It's a lot of material, so let's go through some review questions to practice. Okay, question 1. A 74-year-old with a history of diabetes and hypertension is brought to the hospital 1 hour after waking up with hemiplegia. His family knows that he was in his normal state of health last night, and they think he got up to go to the bathroom 3 hours ago without any deficits. A non-cont head CT, vitals, and basic labs are unremarkable at the current time. What's the next best step? So here it's E. Obtain a limited MRI with DWI and T2 flare sequencing. This is a quote-unquote wake-up stroke. Given that neither the patient nor the family are able to provide a reliable timeline for his last known normal, you can use a limited sequence MRI instead. Remember, if this guy has a bright area of white on his DWI but nothing on T2 flare, then he's within the window for TPA. Okay, next question. Why did the Scarecrow win an award? Because he was outstanding in his field. As the on-call night resident, you're called by a nurse who believes the patient is having a stroke. While on your way to the patient's room, you ask the nurse to urgently obtain which of the following. So this question actually has 2 correct answers because both vitals and glucose are absolutely necessary in the acute evaluation of a possible stroke. The rest of these values might be helpful, but they're not necessary. The only other necessary lab would be an INR in a known warfarin patient. Okay. An 81-year-old female with a pathological history of AFib not on anticoagulation, diabetes, and COPD presents with an acute ischemic stroke. Her blood pressure presentation is 211 over 114. What is your goal blood pressure? Or what is your goal blood pressure in order to give TPA? And what is your goal for the first 24 hours following? C. So this question is a little tricky, but it touches on how important blood pressure goals are in acute stroke care. Remember, you need a blood pressure goal below 185 over 110 in order to give TPA, and then our guidelines for the next 24 hours are that they should remain underneath 180 over 105. I always found it annoying that this had this tiny 5-point discrepancy between these two, but those are the NIH rules. Okay, next question. You're caring for a patient who's 2 days out from a large MCA stroke and has recently been transferred out of the NSICU. When you examine him in the morning, you notice that he's significantly more lethargic than previously and has a blown right pupil. You order a CT, which is shown to the right. The next best step in management is A. Order hypertonic saline and call neurosurgery stat. This patient is at imminent risk for uncal herniation, which you can see here on the CT. Notice how the ventricles appear squished and there's a midline shift. Neurosurgery should be called immediately for a possible hemicraniectomy, but in the meantime you should also be giving hypertonic saline or mannitol to temporarily reverse the swelling. Alright, last question. A 58-year-old male with a history of hypertension and sarcoidosis presents with acute onset left-sided weakness 1 hour prior. A non-cont head CT demonstrates the lesion on the right. His blood pressure is 193 over 104. What is your systolic blood pressure goal? B. So this hyperdensity in the right basal ganglia is an intracerebral hemorrhage, which requires rapid reduction of blood pressure. Studies have shown that targeting a systolic blood pressure of 140 is the best for reducing both morbidity and mortality in hemorrhagic stroke. 180 would be our cutoff for ischemic stroke patients who receive TPA, and autoregulation up to 220 is best for ischemic stroke patients who did not get intervention. It's so important, I can't emphasize, it's so important to know blood pressure goals in these patients because it really has a large impact on their outcomes. And that's all, friends. Thanks for joining for another set of lectures, and I'll see you the next time on Neurology for the Non-Neurologist.